episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome, everybody, again to another episode of our show, bringing you another fascinating guest today who is helping to create a better tomorrow for many people. Today, we have the honor of being joined by Dr. Bryon Bhagwandin, who is co-founder and chief executive officer of a company called Recalibrate Solutions, which is an organization that's focused on ultimately empowering physicians to help eliminate toxic stress from the lives of children, ultimately by monitoring stress system development with a novel 5-minute disposable saliva cortisol test that they've invented. Dr. Bhagwandin has served as an executive for multiple startup companies, spent more than 20 years in medical product development, and possesses a very unique combination of technical expertise, leadership, and business acumen. He has been awarded both bachelor's and master's degree in physics from Purdue and Indiana University Bloomington, respectively. His PhD in biomedical engineering from University of Washington, and he has led multiple product development teams successfully, creating diagnostic, therapeutic, and drug device combination products. He has a very complex understanding of the unique business challenges that have to be navigated when developing medical devices, including broad experience across design controls, quality assurance, regulatory submissions, clinical testing, and obviously once approved, insurance codes, reimbursement models, and everything that happens thereafter. A really unique skill set. Going to be an interesting discussion. Dr. Bryon Bhagwandin, thank you so much for taking the time out of your schedule to talk to us for a little while.
Thank you for having me, Ira. It's a pleasure to be here.
Well, it's great having you. And, you know, Bryon, I was a little bit before the show, I was taking a look back in the scientific literature at a lot of your previous publications, and you were involved in a really interesting wide range of stuff over your career, from salivary diagnostics to nano biochip development, even organ perfusion techniques. Talk a little bit about your background, if you would, a little bit of sort of the early days and what you've been doing up until this point that has allowed you to develop this amazing skill set in medical device development.
Sure. So I, as you mentioned in your introduction, which, by the way, thank you very much. It's a little overwhelming when I listen to it. But I started my career or my education in Indiana. I have 2 degrees in physics. I was very attracted to the physical sciences. I ended up doing a master's thesis in biophysics in Indianapolis at one of the local hospitals, and that ultimately landed me my first career job at Eli Lilly. I spent some time working in central nervous system physiology, and moved from there. Wanted to combine the experience that I had in physics with the experience that I had developed at Eli Lilly, and decided to pursue a PhD in biomedical engineering. And that ultimately took me out to Seattle a number of years ago, when bioengineering wasn't really a mainstream career path that you could go down. It was an interdisciplinary degree, and taking classes in the engineering school, taking classes in medical school, and ultimately I settled on medical devices, and that took me. You really went back. That took me into organ perfusion, which I think is sort of a quintessential biomedical engineering project, because essentially what we were doing is building an instrument to keep an organ alive. So isolate an organ and use your engineering skills to create the rest of the body. A lot of fun and fascinating. Ultimately moved into product development with a local firm in Seattle, and helped them set up a medical device development arm of their organization, and then just moved from project to project from there. Got into the startup world after I left that job, and that was an interesting move, because was developing a portable HIV point of care test that was ideally suited to be used where the disease was most prevalent in sub-Saharan Africa and China and India. So it was a portable device. We used a finger stick of blood and replicated basically a central laboratory test for people who were suffering with HIV. So and ultimately I moved around the country doing those kinds of things, and now I'm in Denver with the current company Recalibrate Solutions, doing another point of care. I don't know if I would call it a diagnostic. I like to refer to it as a monitoring tool.
Mm-hmm. Mm-hmm. And you recently gave a talk at the Neuroscience Innovation Summit. It was entitled Toxic Stress, the Silent Killer in Children, and I encourage everybody to go watch the episode. And in this presentation you give, you start off by introducing the audience to the Felitti and Anda Adverse Childhood Experiences Study, which is this fascinating collaboration between Centers for Disease Control and Kaiser Permanente. Before we get into sort of toxic stress and so the prevalence and the big numbers behind it all, talk a little bit about what the Felitti-Anda study is all about, and why we should be concerned about it or interested in it.
Well, it's interesting that you bring that up, Ira. A little known history about that particular study. It turns out that the Dr. Felitti started before he published that paper, he was a weight loss specialist, and he had a tremendous amount of patients that were very successful in losing weight, but many of them would fall off the wagon, and he started to notice that there was a lot of women who were falling out of his program, and then they would come back and they had gained all this weight back. Mm-hmm. When he started interviewing these particular segment, a cohort of patients who were really struggling, he found that that all of them, without exception, had been sexually abused. Mm. And some of them, the most interesting case that I remember was one where a woman was sleep eating. She lived alone. She would wake up in the middle of the night and eat. And then she would wake up in the morning and she would find dirty dishes in her sink, and she would find dirty pots and pans on the stove and cans opened from the pantry, and she had no recollection of it whatsoever. Turns out that she had started losing weight. She started attracting the attention of men. It triggered her psychology, and she started eating it was a traumatic event response. Mm. He began to then wonder whether or not there were other kinds of trauma within people's experiences, within children's experiences, that ultimately led to other adverse effects. Mm-hmm. And so the Anda, he teamed up with Dr. Anda from the Center for Disease Control, and the two of them began to look at 17,500 subjects, somewhere around there. And they looked at their long-term medical history, and they started doing some correlation between the events that they experienced in childhood. And ultimately, that paper is entitled the Adverse Childhood Experiences Study, or ACEs study. Mm-hmm. It resulted in a 10-question survey that asked people to rank themselves as to where they, how many ACEs they had. So you read the question. If you had an experience, you give yourself a point. If you didn't have an experience, you move to the next question. Turns out 66% of the population have had at least one ACE, and 33% of the population have had 3 or more. And if you get into that category, you are in the high risk category for stress-related illnesses. And they also, in that paper, correlated with those 17,000 subjects, the increased health risks, long-term health risks that you have as a consequence of dysregulating your stress system through trauma. And the statistics are staggering. You are, and I'll just throw a couple of them out there, you're 2 times more likely to be diagnosed with a terminal cancer. Mm-hmm. If you have an ACE score of 3 or higher. You're 2 times more likely to have heart disease. You're 2.5 times more likely to have a stroke. You're 4 times more likely to have pulmonary disease. you're 12 times more likely to commit suicide. It's really extraordinary. And we've known that since, I think, 1998, that study was published. And we still do not have an objective way to screen the physiology for kids whose stress system is dysregulated. Mm-hmm. So that's sort of the foundation, background, and history of adverse childhood experiences, childhood stress dysregulation within children, and the kind of long-term health consequences that it has.
And the other interesting thing I found in your lecture was, obviously there's all this stimulation and the stress response, but the other part that we don't think so much about, the absence of what you term the buffer, something that sorts this stuff out, or at least tries to slow it down in a child's life. And the numbers you present, as you were just saying, you outlined a lot of the medical conditions and the pathologies, but something like 12 million children in the United States alone, a true crisis. The $748 billion in terms of direct and indirect costs of all the diseases, and that's let alone obviously things like suicide, development of developmental situations with the brain. Talk to us a little bit about how we got here in 2020, almost in 2022. And also how sort of those stresses and changes in the buffer have changed over time as we've moved along.
That's a really fascinating question, Ira. And I don't know that I've really been asked that before. So kudos to you, because I've had a number of these conversations. But I think that one of the ways I like to describe it is young children. I mean, stress dysregulation can actually start in the womb, because the stress hormones of the mother are being shared with the child, and we've been able to detect it in our work as early as 6 months in an infant with a dysregulated stress system. So the question is, what's happening? What does that mean? Well, in young children, they tend to mirror their caretakers. So a mother might, let's just hypothetical situation, single parent, mom has 3 jobs and 2 kids, and one of them is 18 months old and the other one is 6. And one day, for whatever reason, she loses one of her jobs. She's struggling financially. She's not sure how she's going to pay her rent next month. But and she comes home and she's making dinner for the kids, and she's thinking about this, and she's worried about this. She doesn't, of course, speak to her 18-month-old or her 6-year-old about this, but she's stressed out, and they can tell. And as a consequence, they mirror her stress, and she has no idea that she really needs to pay careful attention to that and do things that actually buffer those kids, because young kids don't have agency in the world around them. They are observers, and they take what they get. And so the buffer tends to be a relationship with an adult that gives them agency in a situation. Another thing that I think you asked, what got us here in 2022, this is the first generation where elders are not the go-to for information. The elders of our young parents, everybody's grandmother is Google. Mm-hmm. If I have a problem with my child, I am more likely to see what the internet has to say about how I fix a problem than I am to go and ask someone who has actually experienced it raising kids. And there is a big difference. And so I think that there's a number of things that have created the problem, but ultimately, the pandemic, I mean, you quoted 12 million children. That's a number that was estimated prior to the pandemic. They think that number has doubled. They think that 25 million kids in America are suffering with a dysregulated stress system, and there are 74 million kids in America. So that means 1 in 3 are probably, as a consequence of the isolation and the quarantine that's gone on with the pandemic, we really are in the middle of a mental health crisis with our kids.
What exactly is the, well, say a product, but you termed it a monitoring system. What exactly is involved with the device product itself? And then with your broad experience in development of such products, walk us a little through and sort of where you are in development, and then sort of what the path is for this to get out and start helping these millions of kids.
Sure. So, so we wanted to, my co-founder is internationally recognized for her expertise in stress system development in kids, adversity, and in testing interventions. And I first learned about this issue through her, and we were looking, sensing cortisol in saliva is not new. Okay. And we knew this was a problem, and we wanted to address it quickly. And so rather than trying to do some kind of new invention and get early adoption, we decided to try and exploit technologies that were out there, utilize it in this case, and really the innovation is around our value proposition. This is a 5-minute disposable, inexpensive test that can be done using a couple of drops of saliva. And so it's very much like a pregnancy test. It's a paper strip that you put a liquid sample on. Except in a pregnancy test, you can't be almost pregnant or partially pregnant. That's a yes or no. We are looking at a situation where we really want a quantitative result. And so our system is comprised of a disposable test cartridge or strip where you place the saliva sample, and a handheld device that is reused, that's a reader, and you push you put the sample on the cartridge, you put the cartridge into a handheld reader, and 5 minutes later, the reader uploads information to a cloud storage device, or you can upload it to your phone, or you can put it in the cloud and let healthcare professionals look at it and work with it. So that's essentially the system. We are the biggest risk in this whole process is, can we make a test where the chemistry is right, it's accurate, it's accurate across the clinically relevant values that people see and their cortisol levels, and can we get it done in 5 minutes, and can we produce it in an inexpensive way? And all that is associated with the chemistry and the disposable aspects of this particular system. And so that's where we are in our development. We've ironed all that out. That's where we focused. We have those protocols down. We're making test strips of our own. We've demonstrated that we can do it across all the relevant ranges. We've demonstrated we have the accuracy. We've demonstrated that it finishes in 7 minutes, and we estimate that. Well, I won't tell you how much it'll cost, but I don't want to do that just yet. Sure. But let's just say that we can easily get this done for less than half the price of what the current clinical laboratory would charge for a saliva cortisol test. Mm-hmm. So that's where we are. We are in the middle of raising funds right now, and the biggest use of those funds is really to finish up the development effort, and in particular the hardware, the handheld device. We want to deploy those devices to collect the data we need for our regulatory submission. And we anticipate that this is a pretty low risk device as far as the FDA is concerned. Mm-hmm. And so we don't anticipate more than a 6-month time frame in terms of iterations with the FDA. And so we anticipate somewhere between 18 and 24 months, we'll be able to launch this product into the marketplace.
Excellent. And 24 months from now, FDA says thumbs up. Where will we find Recalibrate Solutions devices? Will they be in with the school psychologists and the school nurses, or are these only for clinical? What's the sort of the rollout look at? Because I mean, I could foresee, right? My daughter, I'm so stressed. No, go back to class. You don't have a high cortisol level. Well, wow, this kid is, he's got issues.
Right.
We got to send him to do something else, and so forth. And sort of a second part of that, and obviously I'm getting a few years into the future, but you've had experience with drug device combinations and so forth. Is there potential down the road for, hey, here's the test, and boom, not that a drug will pop out for the kid, but suggestions, the data, a nutritional, suggestion, whatever it may be there to help, at least based on various levels of what you see in the results.
Yeah, again, great questions, Ira, and you're connecting the dots very quickly. I think that the first place that we want to roll this out is to pediatricians' offices. We think that they see the most amount of kids. I think early adopters are going to want to they're going to want to utilize this monitoring tool with every one of their patients, not just a particular segment. And we're going to look initially. We're gonna look at suburban practices.
Okay.
And the reason that we're going to do that is because in the 20 years between 1998, when the original ACEs study came out, and now, there's been a lot of public attention, especially recently, on toxic stress and the effects of stress on long-term health. But it seems to have morphed into a problem for immigrants, Black and brown people who are on the lower end of the socioeconomic spectrum. But the data clearly shows this is a problem across the whole spectrum. And so and we're seeing a lot of high stress environments for the affluent and for the suburban families.
Yep.
And we think that's a good beachhead market, because there's not a parent that I know out there who wouldn't be willing to shell out a few bucks every quarter to make sure that their kids are developing in a healthy way in terms of their stress response system. But we have also designed this, as I said, it's a handheld reader, and we've done that strategically so that we can go immediately from, well, here's the path I see happening. It's being used in the pediatrician's office. The pediatrician would like to see more data. Well, what if they could just send a system home through a prescription and ask the parent to collect the data and upload it to the cloud? And that's why when I described the scenario, the use scenario, the data goes from the device to a storage place where a physician could look at it. And then you take that one step further. So now you've got it being done under physician supervision to certain individuals. You could then expand into school nurses and school healthcare centers. You could then expand into the social work and in-home visitation programs. And ultimately, we see this as something that people would just want to go over to the local drugstore and pick one up and utilize it for whatever situation. I like to say, when I was a college student, I'm facing finals and I finished dinner and I'm trying to decide, should I go to the gym before I start studying, or should I just jump into it? And if I'm looking at my cortisol levels and I find out that I'm a little hyper stressed, maybe I need to go take a run before I hit the books. It might actually help me concentrate. So I think there's room for that, but we see that down the road a little bit. Somebody suggested to me that perhaps high stress employers would be interested in something like this. Firefighters, law enforcement, the military has been looking for something like this for a long time. But what about pilots and heavy equipment operators? I mean, we've seen some accidents, in the last few years recently with pilots and stress. And wouldn't it be great if we could screen those before they ever got behind the controls?
Absolutely. Bryon, what are you hearing, seeing in the in the world of social media, in the sense, obviously, 20 years ago, my kid's stressed, someone's picking on him at school. Today, 100 people are picking on him on the internet. And we hear so much about how this is affected by all, my daughter's on whatever, Instagram for 8 hours, maybe she should get off it and do something else, go for a walk, read a book. And would say, hey, this would be great. So the parent just say, hey, you had too much of this. Your cortisol level's high. Go do something.
Right. Go outside.
Yeah.
Give me your phone and go outside. Yes. I think that I will start my response to that question by saying that, when Anda and Filidi were doing their studies back in the 1990s, there was no internet, there was no cell phones. There really wasn't, the year they published that paper was the first year that the BlackBerry came out with an ability to read your email on the go. So life has really changed, and the source of stress and adversity for kids is very different in 2021, 2022 than it was in 1998. Unfortunately, we're still asking the same questions. Mm-hmm. The way that physicians are currently looking for kids that are at risk for dysregulated stress response is using the original ACEs questionnaire. Social media, I have to believe that is a source of stress for kids. I have to believe that people don't put up their worst moments on social media. They put up their best moments. And, you scroll through some of the, even LinkedIn as a professional social media site, you scroll through and you see everybody's wins.
Yep.
You don't see the, oh grief, we made application to these 4 different accelerators and we didn't get into any of them. Nobody seems to want to post that, right?
Why is everyone raising $1 billion in their seed rounds?
Right. So I do think that there is there's a new sense of identity and worth that comes from strange things like likes and network size, and it can create anxiety. They say the number one source of anxiety, do you know, Ira? Across the board, what do you think the thing you're most likely to get someone anxious about if you ask them to do this?
Ask them to do this. This is a tough one. I don't know, a salary or something. I'm trying to think what everyone's comparing with someone else nowadays. I don't know.
It's an activity that creates anxiety.
Public speaking. Oh, okay.
Exactly. Yeah, public speaking. So now public speaking, exposing yourself, getting yourself out there is the number one source of anxiety. Yeah. And now, people are, you're inside my home right now. Yep. You're looking at, you're looking at my office, my home office. I'm looking at yours. We let people in and we expose ourselves, and we're just inviting. We can invite criticism. Mm-hmm. We can invite, as you said, cyberbullying. What are the sources of anxiety? For some people, I wonder if it's not just making a phone call or having a face-to-face conversation. Yep. These are difficult tasks for some people, and different people, different stressors, different triggers, and we probably ought to be paying attention to. And I ask myself this about my kids all the time, Ira. I never would want to relive my teenage years. My teenagers come to me, and I'm constantly asking myself, is this just a normal part of growing up? Or is this something that I should be concerned about?
Exactly.
And it is not the same world that I grew up in. And boy, I wish I had some real data to be able to say, oh, this is really bothering you. Yep. And me telling you to buck up and just, lean into it, that's probably not good advice in this particular situation. So I agree with you. I think parents would really love to have access to this kind of information.
Absolutely. Most definitely. It is not the same world. Bryon, talk for a couple of minutes. You mentioned you're raising around now. I've only sort of been involved in sort of fundraising for drug development in my career. Talk a little bit. I mean, med tech is pretty hot nowadays. Obviously, there's a lot of other areas where this crossover between bio and technology, information systems, and so forth. What's the current sort of environment out there for novel med tech? What's it been like on the road or on the Zoom road in raising money? Take us a little bit of what you've been up to.
I appreciate that question, Ira. It has been, this has been one of the most difficult, I've spent most of my career in the startup world, and this isn't sort of my first round in terms of raising money. This has been one of the most difficult situations that I have experienced. And I think a big part of it is because maybe it's self-inflicted, because I feel very passionate about this, and this isn't just about being successful. This is really about changing the trajectory for millions of kids. So, but that's what drives me. And there seems to be, and here's one of the biggest barriers that I come up against when I'm talking to people about this. We are at a point where people recognize this is a problem, and what they want is to do something, and so there is a ton of money going into therapy, going into novel programs. I am truly delighted that kids can do yoga classes, and that people can actually program their nutrition on an app on the phone somewhere. That there are mindfulness apps out there, that there are the SaaS applications that will tell you when to breathe and when to take a walk and when to get outside. But we have no idea if they work. I'm sure they work for a certain percentage of the people that are using them, but with the Fitbit, I find that it's not very good at preventative health. Most people who wear a Fitbit and use a Fitbit, they're very healthy. They like the reinforcement of knowing that, yes, I took those steps and I did it. But if you get someone who doesn't like to walk and try and get them to wear a Fitbit, that's not really what they want to do. So we're at a point where, I've talked to so many investors who say, well, we really love what you're doing, but we have a charter that really is focused on how are you directly changing what people do, and what you're doing is identifying the people who need help, but what are you doing to directly influence the outcome? And I guess we're kind of experienced a better understanding of why the solution really begins with testing as a result of the pandemic. We began to realize how important a test was when we started to experience the pandemic. And really, if we're going to get to the root cause and really understand this and really get on top of this, you quoted the healthcare costs, $748 billion annually as a consequence of dysregulated stress during childhood. We're going to have to identify it early and intervene early. And when you do that, when you're able to do that, the cost for intervention goes way down. At this point, we're looking for behavioral changes. And that's the way we've handled mental health in the past. Right? I mean, I don't really, I hate to bring this up, but we had this school shooting from this 15-year-old recently right? And there were all kinds of signs, but nobody really took action.
Yep.
Until there was behavioral change that was totally unacceptable. Unfortunately, there are people who are no longer with us as a consequence. And that's too late, right? Now, I'm not saying that it always is that way, but, you know, when Joey starts acting out in the classroom, you know, when Anna stops eating or starts eating, or, you know, I mean, there are kids self-soothe, self-regulate in different ways. And these are all responses. And if we're waiting till then to see that there's a change that's happening in their physiology, we're going to have a very hard time recalibrating that physiology. But if we can start to look at it when we can't even see that something's going on, but we start to look. I mean, that's what a stethoscope's for, right?
Yep.
You put it up to the heart and you listen and you say, something's not quite right about the way that, you know, your heart sounds, or something's not quite right about the way that your lungs are sounding. Let's take a closer look. And that's really why we call this a monitoring system. We want it to be inexpensive. We want to be able to throw it out. We want to be able to look at it and hope that most of the time everything's fine. It becomes a diagnostic tool when something goes out of bounds. And then we start to ask again, well, what's the source of that? How does that really, you know, is there, you know, if a child might be dysregulated as a consequence of losing a caretaker. Grandma died last week and Joey has not gotten over it. He was really close to her, and, you know, and that's fine. And if Joey a month from now is still sad about grandma's death, that's fine too. 8 weeks from now, if Joey's still not recovering, maybe we need to help him build some resilience and some tools to adapt to that. And so we've got to ask a few more questions. We've got to get in there. We've got to really try and understand. But unless we know what's going on inside the body, we're not going to take action. And that's where we really want to try and make that difference. Sometimes it's simple as just looking at your child in the eye and saying, "You're seen. I get it. I understand that why you're upset, or I understand that you're stressed out about this. I understand that this is really creating a problem for you." And sometimes if it wouldn't bother me, I'm probably not going to make a big deal out of it if it's going to, you know, if it's bothering my child, unless I know that actually it's affecting their physiology, it's affecting their biology, and may have long-term consequences. Then I'm absolutely ready to take the time and to make the time, if you will.
Yep. Well, it's really a fascinating and an elegant solution, and I definitely think you're on the right path, and you know, I'm wishing you the best with not just the development, obviously, but on, you know, continuing on this on the road shows that you're on, especially in this unique era. But yeah, a really fascinating story for everybody that is going to be listening to this particular episode on the podcast networks or watching on the YouTube channel. You've been listening to Dr. Bryon Bhagwandin, co-founder, chief executive officer of Recalibrate Solutions, doing really amazing things to help reduce and eliminate this silent killer of children, this mental health crisis of toxic stress. Check out his recent presentation to Toxic Stress, the Silent Killer in Children, which goes a little more into depth about some of the things we've been talking about. Bryon, it was great having you on the show, and I thank you for taking the time out of your schedule to do this. Obviously, thanks for everything you're doing for all those children, and as we like to say on this show, thanks for helping to create a better tomorrow for them. A really fascinating story.
Thank you. Thank you, Ira. I appreciate that.